Assalamualaikum and good morning, everyone. Could you hear me?
Yes, Prof, we can hear you.
All right, thank you. Thank you, Prof. Vivek, and thank you, Dr. Amber. Very nice presentation. Something very common and important, but yet misdiagnosed, I think. Thank you for that very enlightening talk.
Welcome, Prof.
So today, this morning, I noticed that we have quite a good participants number. The last I checked was about 144. Thank you very much to all of you. I would like to, for those who do not know me, I'm Prof. Yazid, Head of Department of Paediatrics. Today, it gives me great pleasure to introduce Associate Professor Dr. Ruey. He is the consultant pediatric gastroenterologist and hepatologist. So in pediatric, it's not just taking care of the acute gastroenteritis, as you all know, the diarrhea problems, but he also take care of basically the issues that relate to the liver, more likely in children due to the biliary atresia. And we have some programs done before for our biliary atresia patients, but it went into a bit of dormant because of certain issues, and now it's being revived. So Prof. Ruey will talk to us today on the UMMC Pediatric Liver Transplant Program, a short report. Over to you, Prof.
Thank you very much, Prof. Yazid, for your very kind introductions. Yeah, let me share my screen. Can everybody see my screen? Yes?
Yes, I can see that.
Thank you. Right, good morning. Thank you for attending this Wednesday morning hospital CME draw online. So I'd like to share with you a few words about our progress in the pediatric liver transplant of these hospitals. Right. Oh, it's basically a very, very short report because we just started for less than 2 years officially. Right. So some history about pediatric liver transplant. Autotopic liver transplants means you remove the diseased liver and replace with a new liver. Has been a standard care for children with end-stage liver disease and many other liver-based metabolic disorders. In fact, the first transplant, the first human attempted for liver transplant was a pediatric patient back in 1963 by this Dr. Thomas from the States and his team. It was attempted again to a 3-year-old boy with biliary atresia. Biliary atresia, for information, is the commonest indication for pediatric liver transplants worldwide. Unfortunately, the first attempt was unsuccessful and the child succumbed to bleeding while on table. 4 years later, the same team continued to take up the challenge and managed to do a successful pediatric transplant in 1967. And subsequently, there's another 7 transplant and 4 survived beyond 1 year. So the initial attempts, of course, there are multiple technical, surgical, and hemostatic challenges, and more importantly, there are lack of effective immunosuppressant drugs. So the regimes are solely rely on very high dose of steroids and some mercaptopurine, where the overall outcome remain poor. So, and for the recent years, for information, the 1-year survival rates are beyond 90% in the good centers, and 5 to 10 year survivals are beyond 80%, and are all secondary to improve surgical skills over the years, the organ preservation techniques. Of course, we have more newer immunosuppressive agents, as well as some mass cumulative global experience that has been shared among the different centers from different countries, and that has dramatically changed the prognosis of many infants and children with liver failure and metabolic diseases. So the success has increased the demand from the very scarce cadaveric donor pool, and hence the living donation program has kickstarted. And the first successful living donor liver transplantation happens back in 1989. And this problem particularly important in Asia because the religious and cultural sentiments, as well as the state of medical infrastructures, has posed a challenge to brain death organ transplant organ donation programs. So some countries do, such as our neighbor in Singapore, came up with altruistic or Good Samaritan donors, and this has been the emerging trends. Of course, as the reports and the results are still anecdotal because concerning of donor safety. Sorry, yeah. So come back to who should want transplant? Who should need a transplant? So traditionally, end-stage liver disease, of course, for those who predicted life expectancy less than 1 year, for those with acute liver failure who is no sign of recovery, unresectable liver tumors, of course, without metastasis, as well as liver-based metabolic diseases, those impose very poor, sorry, I think there's something wrong with the slides. Yeah, impose very poor lifestyles. So other traditional indications for PEDS transplant will be cholestatic liver disease. Again, you see biliary atresia and top in the list. Tumors, unresectable tumors, as I mentioned earlier, and some metabolic diseases who are very, very difficult to control, frequent crises who require interventions, as well as recurrent hypoglycemias, and of course, acute liver failures from all the causes, including autoimmune diseases, right? Others, such as Chiari syndrome, where there is a hepatic vein outflow obstructions, and liver cirrhosis of unknown origins. Hepatitis B and C is no longer contraindicated. It is with the advancement of antiviral therapies, hepatitis B and C cirrhosis is an indication for transplant. Of course, autoimmune liver disease, as well as emerging problems in our populations where non-alcoholic fatty liver disease will be foreseen to be the major indication for liver transplant for both children and adults in the future. Yeah. So of course, there are other controversial indications, for example, mitochondrial diseases, propionic acidemias, where all these diseases with transplant couldn't really answer the question of whether the patients will improve after these procedures. So then the indications remains controversial for this group of patients. Other non-life-threatening but significant impaired quality of life indications are failed Kasai surgery for those patients with biliary atresia, where they have persistent jaundice more than 6 months, and when they have recurrent ascending cholangitis who require hospitalizations for IV antibiotics, and those with recalcitrant ascites, and as well as further complicated with spontaneous bacterial peritonitis, and those with complication of portal hypertension, such as variceal bleeding and severe hypersplenism, hence results in thrombocytopenia and leukopenia, right? And of course, at the extreme end of chronic liver disease, those who suffer from hepatorenal syndrome, hepatopulmonary syndrome, as well as hepatic osteodystrophy. And not uncommonly, growth failure or severe growth watering will be the indication for transplant for many children with chronic liver disease. Although the function has been, the function of the liver remain preserved, but overall growth of the child is poor. So that has been indication for transplant. And severe debilitating pruritus. Just like those patients with chronic renal disease, patients with chronic liver disease, a big group of them do suffer from severe pruritus with a very poor quality of life. Professor Lee from our unit used to mention, if we have 24 hours in our day, these children, this patient, they will scratch 25 hours. Yeah, you can imagine how bad is their quality of life. So for them, transplantation will totally revert these problems. And of course, for those who have metabolic liver diseases, intractable seizures, hypoglycemias, and hyperammonemia, which is refractory to treatment, will be the indications for transplant. This is an example of a child with severe, with Alagille syndrome, with chronic liver disease. As you can see, the disfigurement that has caused multiple xanthoma, xanthelasma, as well as pruritus. This child has severe pruritus and have been scratching most of the time in the day. And one of the most fearing condition for those children with chronic liver disease will be variceal bleeds, and this can it can be potentially life-threatening, and it's always cause a severe family distress when when parents are handling this. So these are not uncommonly seen for those children with liver cirrhosis, especially secondary to biliary atresia. And as I mentioned earlier, recalcitrant ascites who cause significant respiratory embarrassment, as you can see in these pictures. So what is a contraindication? After talking about all the indications, what is a contraindication for liver transplant? The absolute contraindication for transplant were malignancy, extrahepatics, especially when there's metastatic diseases, or those who have irreversible and severe neurological injury, especially those who have metabolic disorders when the CNS, central venous system, has been significantly compromised because of the disease, and with the transplantation will not be able to revert the present neurological state. So it will be contraindicated for transplant. Of course, those patients with multi-system, multi-organ failures, active and uncontrolled sepsis, and other uncontrolled life-limiting defects in other critical organs. So all these children will deem unsuitable for a liver transplant surgery. Okay, the timing for transplant, best timing always difficult to plan, because many children may have compensated liver disease for many, many years. Physically, they might look fairly okay during assessments, but biochemically, it will show a significant abnormalities and frequently. So, and at this stage, it will be difficult to convince the parents to subject the child for such a major surgery and the long-term care after that. So most useful guide will be to plan the timing for transplant for children will be persistent raise in total bilirubin, all right, and a prolonged clotting profile, which is not correctable by vitamin K, which shows and persistent hypoalbuminemia, that will be a main indicator showing that this liver is decompensating. And of course, as I mentioned earlier, faltering growth will be an important indications, as well as the consequences of portal hypertension, like refractory ascites and recurrent variceal bleeds, just as I mentioned in the previous slides. So I just like to bring up this paper written by Professor Kelly and the team, so renowned pediatric hepatologist in the UK. And this paper is importantly telling us that children with prolonged liver disease has the poorest cognitive outcome despite successful transplantation. So suggesting that prolonged cholestasis before transplantation adversely affect the neurodevelopment and reinforce the need for timely interventions. So this paper actually tells us that do not satisfy with the patient's status quo conditions. If they are in chronic liver disease, don't be happy that these patients' liver function is still okay. But we know that the longer they live with the chronic liver disease, the poorer the cognitive outcome is indicated for this. And the team also published this paper some time ago. As you can see, the outcome of our country for patients who underwent liver transplant is so much poorer as compared to other countries back in 2009. So, and this has been, as mentioned by Prof. Yazid during the introductions, this service has been rather lacking in the country, although there was a program running in the country, but for some reason it hasn't been active, and children with end-stage liver disease has not been really truly benefited from it. So a few words about service of liver transplantations in Malaysia. It actually started in a private hospital Subang Jaya Medical Center from 1995 to 2004, where they transplanted total 51 patients. So since 2004 April, Selayang Hospital kickstarted the transplant program. For the 13 years between 2002 to 2015, there are total 81 transplants. There are 43 adults, which is about 53% of it, and pediatric of 38 cases. Why do I pick this time frame 2002 to 2015, but not beyond? Simply because I think for some reason pediatric transplant, last pediatric transplant was happened in 2015, and subsequently it was inactive after that. So out of the 38 cases of pediatric transplant, there are 18 living-related cases and 20 cadaveric. So the main indication for pediatric liver transplant remain biliary atresia. So this graph actually shows the same information as per the previous slides. So and as well as this shows biliary atresia is the main indication for transplant. So how about the journey of transplant in Malaya Medical Center? Our children with end-stage liver disease under our care has been sent for living donor liver transplantation all these years since 2014 actively to overseas transplant centers because of the lack of service in the countries. So with that, within this period of time, a time span of 4 years, we have sent 33 to Shanghai, Renji Hospital of Shanghai, where we have 29 success and 2 mortality before transplant and 2 mortality post-transplant due to primary graft failure as well as sepsis. We have 8 patients transplanted at National University Hospital of Singapore and 4 at Taiwan, both at NTUH, National Taiwan University Hospital, as well as Changgung Memorial Hospitals. And there are also a significant numbers of patients, 11 transplanted at India, right? So altogether, at the time span of 4 years, we have 57 patients transplanted overseas. So the main indication for transplant until 2018 is remain the same as compared to the Selayang statistic as well as the world statistic. Biliary atresia comprise of more than 95% of it. So this is the first Malaysian child transplanted at Renji Hospital of Shanghai. It's a child with biliary atresia and stage liver disease. Right, this is how she looks like after transplant. And she's now standard 2, standard 3 healthy girl now, right? So again, Jacqueline has a rare form of hepatic fibrosis of unknown origin. So she was severely failure to thrive upon presentation, and this is how she looks like after transplant. Yazid came to our doorstep. He is end-stage liver disease, secondary to biliary atresia. As you can see, despite jaundice and wasted, he's also scratching on the second pictures. He constantly scratching and with a very poor quality of life as well as developmental delay. And this is how he look like after transplant. So there are many patients, as I show in this slide. Those are all transplanted overseas, and you can estimate even though these patients are getting better, they improve, they have a new life, we say, after transplant, but we can imagine how much of cost has been lost to overseas all these years because of sending patients for liver transplant in overseas. So with that, the idea of developing our own transplant program has emerged. So as significant numbers of patients has been sending to China for transplant, that has alerted our ambassador of Malaysia in China, as well as our Consul General of Malaysia in Shanghai, to visit the center, the transplant center in Shanghai, and the team do come over to visit our patients, to review our patients in UMMCs. So the relationship has been slowly building up and slowly strengthened. And back in 2015, about 5 years ago, we officially launched a program sponsored by Sinchiu Foundation. As you can see on the right-hand side, this is a proposal, a paper proposal written by Prof. Yong, the lead and the chairman of our liver transplant team. So I think about 1.5 years after the launch of the programs, we successfully did the first adult living donor liver transplantations on January 2017 with the team from Queen Mary Hospital of Hong Kong, who was the mentor and teachers of our Prof. Yong and Prof. Ko from hepatobiliary teams. And this is the recipient, Chin Heng, and the donor brother. Both are doing extremely well after the surgery. For information, Chin Heng also has chronic liver disease secondary to biliary atresia. So few months down the line after the first successful transplant, this 13-year-old boy came to our doorstep for acute liver failure of indeterminate etiologies. Because of his rapidly deteriorate conditions, we decided to take up a challenge for an emergency transplant with donor being the father. And again, we were assisted by the team from Queen Mary Hospital of Hong Kong. But it's rather unfortunate this child didn't make it because he succumbed to vascular complications and multi-resistant gram-negative sepsis at week 4 post-transplant. He passed away in PITS ICU. It was a sad story, and it was, of course, it was setbacks for the programs, but nevertheless, we continue to pursue our collaborations, especially for PITS transplant. And in 2017, probably visited Department of Liver Surgery of Ruey Hospital to understand more about their transplant program over there. And a year later, 4 of us, Prof. Yip, Prof. Yong, me, myself, and our gastro trainee at that time, Dr. Kam, visited and observed PITS transplant in Ruey hospitals, and we met some of our patients who are waiting for transplant in Shanghai hospitals, right? So the effort come to slowly become fruitful. In 2019, we managed to sign the MOU between our hospitals and Ruey hospitals for the collaborations in pediatric living donor liver transplant program, signed by our previous pengarah, Prof. Tunku Kamaro. And soon after that, 16 of us from the multidisciplinary team, surgeons, radiologists, intensivists, anesthetists, pediatric hepatologists, pediatric intensivists, even nurses, OT, theater nurses, as well as PITS ICU nurses, depart to Hospital Ruey for a 1-month intensive training for liver transplant, right? So these are the active program of transplant. During that 1 month, they were posted to respective stations to carry on their role and to strengthen their skill and knowledge in their respective field. So as you can see, they are actively participate in the action during that period of training. So a month after that, after returning from training, we have our first, after training, we have our first and second pediatric living donor liver transplant with Team Shanghai, August 6 and 7 August last year, 2019. It was a successful transplant. The first candidate was this 10-year-old girl with end-stage liver disease secondary to biliary atresia. She was critically ill right before transplant, and the father was a donor, and this is how Shafiqa looks like recently. So second transplant, the next day was Isra, who has chronic liver disease secondary to biliary atresia. As you can see, he has severe failure to thrive. And after transplant, this is how he looked like. And this is the latest picture of Isra during recent follow-ups. And the third transplant, I think 2 months later, again, a girl with chronic liver disease secondary to biliary atresia. when whom the mother is a donor, was a donor, and this is how Shifa looks like after transplant. Before we want to progress further in our program, of course, the world is hit by COVID-19, and this has interrupted the progress for the transplant, and we have the program was interrupted for more than 6 months. Of course, the disease patients can't wait for our timing. The disease continue to progress, and we have come to the extent where something needs to be done for this group of children and patients with chronic liver disease. So is it time to stand on our own, since we can't send our patients out and our mentor from overseas can't come over to assist? So with that, we kickstarted our own independent transplant June this year during COVID-19 pandemic without any external assistance for this 1-year-old boy with end-stage liver disease, secondary to biliary atresia. Phoenix was successfully transplanted with the liver donated by the father. This is Phoenix. And subsequently, during the second attempt, again, we lost this lovely boy who has end-stage liver disease secondary to biliary atresia due to surgical complications. The whole team mourned for the loss, and this again is a great setback for the programs. But nevertheless, for the subsequent month, the team wiped away our tears and continue to take up the challenge to move on. And in August, we transplanted this 5-year-old girl with Alagille syndrome and chronic liver disease with poor quality of life secondary to faltering growth as well as severe pruritus. Fariha was well after transplanted, and this is how she looks like post-transplant. September, we transplanted Tan Yansi, a 1-year-old girl, end-stage liver disease secondary to biliary atresia. This is Yansi post-transplant, and this is during follow-up. November, we have a very ill boy from Kota Baru, end-stage liver disease secondary to biliary atresia. The whole team spent lots of time and effort to maintain, to prepare him for transplant. And with the hard work, this is the fruits we harvest. And this is how he looked like during follow-ups. And before the year end, we have Hakim. Hakim just being discharged a few days ago. He was transplanted for chronic liver disease. And this is how he looked like post-transplant. So some statistics to show, and as you can see, the graph for the beginning of the year, for the earlier years, all our patients are transplanted overseas. We have about 8, 7, and the number increased to 13, 21 in 2018. And starting from 2019, you can see the numbers being transplanted in our center is getting more and more, and we foresee we will do more in the coming years. And of course, there are some mortalities, but I would say overall, our patients are doing pretty well for those who are done locally, as well as for those who are done overseas. Of course, we do see complications and of transplants, commonly such as acute graft rejections, but all of them has been fairly easily handled, right? So, and again, these are our statistics as compared to Lion hospitals. We show the same frequency of primary diseases where biliary atresia is the main indications, right? So all this cannot be achieved without the hard work of all these people. With my sincere heart, I would like to thank all the people that have put their pictures. Of course, I might have missed many of them. There are still many heroes behind the scenes, but these are the people that I would like to thank, because this is a great team to work together and that make this program success. So from all of them, we learn what is teamwork. Teamwork is coming together at the beginning and keeping together to progress and be working together to make it a success. So not forgetting To our dedicated mentors and teachers from Shanghai, a big thank you to them. And the journey continues. With that, I thank you for your very kind attentions.
All right. Very lovely, Prof. Ng. Thank you very much for that very interesting, very encouraging work by the whole team. I think the pictures tells us everything. It tells us how much we can do and how much we able to do if we all work together. Yeah, so it is very, very nice, and I think what you, your team, and Prof. Yong, especially from the surgical department, have started, that is very, very important for Malaysia. As we can see, there is a lapse of a few years where we do not have any transplantation done in Malaysia, but we still have lots of numbers, a good number of patients that we actually send out to overseas for the operation. And I think we have also proved in this year, especially when the COVID hits us, there's positive things coming out of it, where we managed to do our own transplant. And that is the way to go, I think. Yeah. Yes, we learn from others, but we also put our foot down and move on. Yes, there is some setbacks, there is some sad story behind it, but that makes us better. That actually makes us stronger. View of the time, I think probably there would not be any question, but I would love to just listen from others. Anyone who wants to put in anything there on the Q&A or box, I think Prof. Ng will be able to come back to you and discuss and also answer some questions. Thank you very much to all the participants today. Thank you very much, Prof. Ng, for enlightening us, and thank you very, very much for the multidisciplinary team together with the dean and as well as the director of the hospital for allowing this kind of very great effort to be done in Malaysia. So hopefully we continue and we persevere despite all the challenges that we have. Thank you very much to all.
Thank you very much.
Yeah, thank you very much to all for listening to this UM at Breakfast Symposium. Have a nice day, everyone. Thank you.